Addressing burnout in the behavioral health workforce through organizational strategies. Chapter 1. Behavioral Health Equity. Behavioral health equity is the right to access high-quality and affordable healthcare services and supports for all populations, including Black, Latino, and Indigenous and Native American persons, Asian Americans and Pacific Islanders and other persons of color, members of religious minorities, lesbian, gay, bisexual, transgender, and queer LGBTQ+ persons, persons with disabilities, persons who live in rural areas, and persons otherwise adversely affected by persistent poverty or inequality. As population demographics continue to evolve, behavioral healthcare systems will need to expand their ability to fluidly meet the growing needs of a diverse population. By improving access to behavioral health care, promoting quality behavioral health programs and practice, and reducing persistent disparities in mental health and substance use services for under-resourced populations and communities, recipients can ensure that everyone has a fair and just opportunity to be as healthy as possible. In conjunction with promoting access to high-quality services, behavioral health disparities can be further mitigated by addressing social determinants of health, such as social exclusion, unemployment, adverse childhood experiences, and food and housing insecurity. In all areas, including the workforce, SAMHSA is committed to behavioral health equity. Exhaustion, feeling depleted, overextended, and fatigued. Depersonalization, being detached from oneself and emotionally distant from one's clients and work. Feelings of inefficacy, having a reduced sense of professional accomplishment. Burnout has physical and emotional consequences for individuals and impacts their work with clients and within an organization. To fully address burnout, organizations need to adopt strategies that improve their organizational culture and climate to modify the 6 drivers of burnout: workload, control, reward, community, fairness, and values. Focus of the guide. The guide provides an overview of the prevalence of burnout among the behavioral health workforce, factors that contribute to burnout, and the implications of burnout. This guide presents evidence-based organization-level strategies to address burnout. It outlines broad lessons learned from previous studies investigating the complex causes and mediators of burnout, focusing on the domains of workload, control, reward, community, fairness, and values. The guide provides examples of organizations implementing organization-level strategies to address burnout within the healthcare landscape. These approaches will assist organizational leaders, human resources staff, and other staff interested in implementing strategies to address burnout within the behavioral health workforce. Behavioral health provider. Behavioral health provider refers to professionals addressing mental health and substance use disorders, including, but not limited to, psychologists, psychiatrists, nurses, peer support specialists, patient navigators, therapists, addiction and mental health counselors, recovery coaches, caseworkers, social workers, psychiatric aides and technicians, paraprofessionals working in psychiatric rehabilitation and addiction recovery fields, and additional medical and other professionals who manage behavioral health issues. Primary care providers and their teams may also provide behavioral health services. The behavioral health workforce includes a diverse set of professionals who work in a broad range of settings, including community-based outpatient or inpatient programs, primary and emergency healthcare settings, criminal or legal settings, social services agencies, and educational settings. Staffing shortages and high rates of turnover place enormous demands on the workforce, and jeopardize the provision of care, especially to underserved individuals. Moreover, the nature of the work, which often involves helping individuals manage mental health issues, substance use issues, trauma, or behavioral health crises, can be emotionally taxing. The behavioral health workforce experiences high levels of work-related stress, relatively low salaries, high student debt, and full caseloads. These combined factors place individuals working in the behavioral health field at high risk for experiencing burnout. Over 50% of behavioral health providers report experiencing symptoms of burnout. The rate of burnout will likely increase given continued growth in the number of people seeking behavioral health care along with behavioral health staffing and retention challenges. Although this guide focuses on behavioral health workers, burnout may affect all health workers. Burnout can have lasting harmful effects on a provider's physical and mental health, including insomnia, hypertension, depression, anxiety, and substance use. It also has both direct and indirect costs for organizations. Providers experiencing burnout may become disengaged from their jobs and are more likely to leave their positions. This affects clients' access to care and the quality and continuity of their care. As a result, organizations must invest considerable additional resources into constant new hiring and training. Burnout is distinct from, but often related to, other concepts listed below. These concepts can accelerate an employee's likelihood of experiencing burnout or exacerbate issues of burnout. Moral injury describes the psychological, social, or spiritual distress caused by committing or failing to prevent or stop an act that is inconsistent with an individual's values. Vicarious trauma is the compounding impact on behavioral health staff of working with patients who have experienced traumatic life events. Compassion fatigue is the decreased capacity to care for clients because of repeated exposures to their suffering and trauma. Second victim syndrome occurs when a provider becomes traumatized by a client's traumatic event during patient care, especially as a result of a medical error, resulting in the provider feeling personally responsible for the client's outcome and doubting their clinical skills, knowledge base, and career choice. Organizations are positioned to mitigate impacts on behavioral health staff by implementing policies and programs that prevent and address perpetual cycles of burnout. Burnout defined. The World Health Organization (WHO) defines burnout as an occupational phenomenon, conceptualized as resulting from chronic workplace stress that has not been successfully managed. Burnout is not a medical or mental health diagnosis. It is distinct from, although can be exacerbated by, mental health disorders e.g., anxiety and depression, general stress, job dissatisfaction, secondary and vicarious trauma, and compassion fatigue. Burnout is typically characterized by three dimensions: sustained feelings of exhaustion, depersonalization, professional inefficacy. The WHO noted that burnout applies strictly to occupational settings and does not apply to experiences in other aspects of life. Addressing burnout may include strategies to impact the symptoms of burnout, but as a workplace phenomenon, improving burnout requires system and organization-level solutions. Prevalence of burnout. An estimated 50% of behavioral health providers report feeling burnt out due to high levels of stress, low salaries, perceived lack of career advancement opportunities, and increased caseloads. Studies show the prevalence of burnout among mental health professionals is substantial and varies depending on the sample and setting. For instance, one review found burnout prevalence ranged across studies from 21 to 67%. Signs and symptoms of burnout. Burnout is a spectrum with many symptoms that can vary in severity. Common signs include sense of failure, procrastination, physical illness, helplessness, loss of motivation, withdrawal from relationships and responsibilities. Burnout is more prevalent among physicians than in the general population, 16 and especially among psychiatrists, with burnout rates reported as high as 78% in 2017-2018 surveys. A review from 2018 found that between 20 and 40% of psychotherapists experienced symptoms of burnout. In another survey from the same year, the prevalence of burnout among substance use treatment counselors was 33%, with 65% of opioid treatment program counselors reporting some symptoms of burnout. Burnout rates for specific provider roles, disciplines, or treatment settings are less available. Some studies indicate that mental health counselors working in outpatient settings in the public sector have higher rates of burnout than inpatient or private practice providers. Reasons for this include less autonomy and workplace contextual factors, such as level of coworker support or perceived fairness of the organization. The COVID-19 public health emergency contributed to significant increases in the burnout prevalence among the healthcare workforce. This is especially true for communities of color, who experienced COVID-19 related challenges more acutely and severely than their white counterparts. In particular, physicians of color reported higher rates or an onset or increase in burnout due to COVID-19. Codes of ethics related to burnout. Many professional organizations have sections within their code of ethics around professional competence that create an ethical imperative for addressing burnout. For instance, the American Psychological Association's APA Code of Conduct requires providers to take steps to stop working when they experience issues interfering with their work. The National Association of Social Workers Code of Ethics states that social workers who are aware of a colleague's impairment due to psychosocial distress or mental health difficulties that interfere with practice effectiveness should consult and assist when possible. Compared to urban substance use treatment counselors, those in rural settings have reported more contributors to burnout, including office politics and low occupational prestige. Greater shortages of behavioral health providers in rural settings, with about 13% of rural counties having no psychologists, psychiatrists, psychiatric nurse practitioners, social workers, or counselors, may compound these factors. Studies on the prevalence of burnout among different socio-demographic groups are limited and many show inconclusive or inconsistent findings. A 2021 systematic review exploring racial and ethnic differences in burnout reported mixed results, with 2 studies finding higher rates of burnout among racial and ethnic populations that are typically underrepresented in the medical field, 2 finding lower rates of burnout, and 9 finding no difference. Individuals may experience burnout differently due to stressors within or beyond the work environment, such as family or childcare pressures, lack of access to transportation, limited support from social networks, or gender or racial discrimination. Burnout is likely underreported, due to societal stigma of related concerns, e.g., mental health diagnoses, and providers' concerns about licensing repercussions. 29 More research is needed to explore rates of burnout among behavioral health providers, including analyses focused on differences by socio-demographic groups. Contributors to burnout. The causes of burnout can occur at organizational, interpersonal, and individual levels. Organizational factors are increasingly recognized as the primary contributors of burnout, with a broad range of employees in a 2018 poll identifying the top 5 reasons for burnout as 1. Unfair treatment at work. 2. Unmanageable workload. 3. Lack of role clarity. 4. Lack of communication and support from their manager. 5. Unreasonable time pressure at the organization level. Conditions that contribute to burnout can be classified into 6 core domains: workload, control, reward, community, fairness, and values. Vulnerabilities in each of these domains contribute to the 3 dimensions of burnout. Definitions of each domain and how it contributes to burnout are below. Chronic excessive workload contributes to burnout by preventing employees from having the opportunity to rest and recover. It hinders their ability to meet job demands. Both quantity and type of workload contribute to burnout. Working overtime, excessive hours, or time pressures can lead to emotional exhaustion. Work that staff perceive to be in addition to their usual role, such as administrative tasks, or work where they do not have the necessary skills to execute it due to lack of training or insufficient support, can increase one's workload and lead to burnout. Understaffing can also contribute to workload pressures and increases burnout. Lack of control relates to an employee's capacity to influence their workload and/or work environment, professional autonomy, and access to resources that support their work. The inability to control these factors contributes to job disengagement, which, over a sustained period, can lead to burnout. Burnout due to perceived lack of control is especially seen in providers who work in fast-paced, highly demanding environments, such as inpatient settings. Insufficient or inconsistent recognition and reward can contribute to employees feeling that their work are unimportant or undervalued. These feelings can lead to burnout and employees withdrawing from their work. Low salaries and limited career advancement opportunities are common across behavioral health settings. Insurance networks provide low reimbursement rates for behavioral health services, causing providers to be underpaid. In some instances, insurance networks prohibit reimbursement altogether for peer counselors, community health workers, licensed professional counselors (LPCs), and marriage and family therapists (MFTs). Community lack of support and trust among coworkers can contribute to unresolved workplace conflict, leading to feelings of exhaustion and depersonalization. Organizational environments centered on equity and respect enable employees to thrive and form positive connections. Supervisory skills in communication, conflict resolution, and team building also impact the sense of community within a work group. Siloed decision-making that is not transparent or does not engage employees at all levels can contribute to feelings of unfairness or disrespect. Inequitable procedures can lead to cynicism towards one's job, which can result in burnout. Although these organization-level factors are the root contributors, symptoms of burnout can be exacerbated by interpersonal relationships, individual experiences, or personality. Depending on the situation, interpersonal relationships with clients, families, and colleagues can provide mediating effects or create additional stressors that contribute to burnout. Family-related obligations and work-family conflict can create role pressure, role strain, and additional demands on individuals, leading to burnout. Individual-level factors that contribute to burnout include the following: low level of hardiness, lacking a sense of power over events, disengaging from life activities, and resisting change. External locus of control, attributing achievements to others or chance versus attributing achievements to oneself, an internal locus of control. Poor self-esteem, lacking confidence in one's abilities. Avoidant coping style, responding to stressful situations passively rather than actively. Ongoing systemic issues in the behavioral health landscape further compound these organization, interpersonal, and individual-level factors, including workforce shortage. The Health Resources and Services Administration (HRSA) projected that by 2030 there will be a national shortage of 12,530 adult psychiatrists and 11,530 addiction counselors. In 2021, the U.S. Department of Health and Human Services (HHS) designated 5,930 geographic areas, population groups, and facilities as having shortages in mental health professionals, with 39% of the U.S. population residing in these areas. Increased behavioral health needs. In 2020, 14.5% of respondents aged 12 and over had a substance use disorder in the past year, and 21% of respondents aged 18 and over reported any mental illness in the past year. In the same year, 30.5% of adults with any mental illness reported an unmet need for services in the past year. 40 in a survey by the APA, over 50% of psychologists reported seeing more clients for anxiety, depression, and trauma and stress-related disorders, compared to before the COVID-19 PHE budgetary considerations. During the 2009 to 2011 recession, states cut more than $1.8 billion cumulatively from their mental health budgets and have been slow to rebuild. As of 2015, fewer than half of states had increased their budgets. At the same time, certain behavioral health providers, including community health workers, are unable to be reimbursed for their services in some states. Stigma related to behavioral health services. Behavioral health stigma, including among behavioral health providers, negatively impacts engagement with behavioral health services. The peer support workforce in particular often reports feeling stigmatized by colleagues and less valued within their organizations. Shifts in service delivery and policies. The rapid uptake in the use of telehealth is a result of the COVID-19 fee required providers to adapt to new demands. In 2020, 96% of psychologists reported treating clients remotely, and in 2021, the number of psychologists using a hybrid approach increased by 17 percentage points, from 33% in 2020 to 50% in 2021. In addition, new transparency laws, effective January 1, 2022, which are designed to give clients cost estimates upfront, present challenges for behavioral health providers, as diagnoses can take time and treatment needs often change. Systemic inequities. For communities of color and sexual and gender minority populations, contributors to burnout are exacerbated by systemic inequities and discrimination within and outside the workplace, including interpersonal racism, racial injustice, homophobia, and transphobia. In 2022, the U.S. Surgeon General called for a whole-of-society approach to address health worker burnout at the systems level and to build a thriving health workforce. This approach, in part, highlights the need to reevaluate financial incentives, create more human-centered health information technology, and rebuild trust through public-private collaborations and increased social support programs for health workers. The cost of burnout. Burnout and responses to burnout can be costly for organizations. Burnout is associated with increased rates of medical error, resignation from the workforce, and turnover. Estimates for average turnover rates in the behavioral health workforce are around 30% annually, and higher than other high turnover professions, such as physicians and teachers. Organizations can face significant costs due to turnover, lost clinical hours, and absenteeism. Additionally, burnout negatively impacts client outcomes, creating a patient safety issue. Studies exploring the costs of turnover and lost clinical hours have estimated an annual loss of $7,600 per physician, and conclude that a 1% increase in registered nurse turnover will cost the average hospital $270,800 per year. However, addressing burnout requires upfront, short-term costs for organization-level change. These costs may be significant and include both direct, e.g., purchases of new technology or training fees, and indirect, e.g., staff time necessary for participation or increased supervision costs. While long-term benefits may offset these costs, they might be difficult for some organizations to cover. Many organizations, including small, community-based, behavioral health organizations, may have limited resources to support organization-level change, due in large part to reliance on potentially inconsistent federal, state, or philanthropic funding streams and chronic underinvestment in behavioral health services. Federal and state policies, regulations, and legislation may be able to alleviate some systemic issues in the behavioral health workforce by expanding opportunities and funding for workforce training and reimbursement for behavioral health care. Academic institutions and accreditation bodies can also integrate mental health services and supports into training programs to better support the well-being of students and trainees. Implications of burnout. Burnout has physical and emotional consequences for individuals, as well as implications for their organization and interpersonal relationships with clients, family, and friends. Preview of strategies to address burnout. This guide focuses on organizational strategies to address burnout. Organization-level factors, such as excessive workload, lack of transparency in policies and procedures, and role autonomy, are stronger predictors of burnout than are individual-level contributors. Organizational approaches to remedy burnout target the root causes of burnout, while individual strategies typically help to address or mitigate symptoms of burnout. Individual approaches are important for personal resilience and managing stress. However, interventions targeting the symptoms of burnout have limited long-term impact than when combined with organization-level interventions. Examples of organization versus individual-level strategies to address burnout. Strategies targeting organizational processes and culture. Practice delivery improvements, workflow modifications, institutional policy changes, e.g., time off and leave policies, organizational culture change, expanding resources for staff, e.g., childcare and family support programs. Strategies focused on fostering individual coping mechanisms. Stress management and resilience training, self-care tools and mindfulness-based approaches, e.g., meditation, yoga, professional development trainings to improve confidence and work performance, somatic therapy. Organizational strategies have the potential for a more enduring impact on reducing burnout because they affect all staff and place accountability on the organization rather than the individual. Scaling up effective organization-level strategies has the potential to reach more people and have a greater impact than individual-level interventions. The chapters that follow describe evidence for organization-level strategies to address burnout. Chapter 2, Strategies to support implementation of organization-level interventions. Chapter 3, Case studies highlighting organizations that have implemented organization-level strategies. Chapter 4, Recommendations for ongoing evaluation. Chapter 5,